Yes, sir. Good evening, everyone. Myself, Dr. Batsal Gupta. I'm a second year resident in Dr. D.Y. Patil Hospital, Medical College. Uh, so the topic of my discussion is the comparative study of functional outcome of fracture treated with plating versus conservative for complex proximal humerus fracture in elderly. Proximal humerus fracture are seen most commonly in elderly population. The goal of the treatment should be to maximize the function of the shoulder and to minimize the chances for treatment failure. Roughly 80% of them are minimally displaced and need non-operative management. The remaining 20% of them are displaced and unstable fractures which need operative intervention. The treatment of proximal humerus fracture has been subject of much controversy and confusion. This is due to a wide variety of fixation devices available, challenging operative techniques, complication from surgery reportedly varies between 11 to 50%, whereas the non-operative treatment can yield less than satisfactory result with being minimally painful. So the present study was done in our tertiary care center to compare and evaluate the functional outcome of complex proximal humerus fracture treated with plating versus conservative in elderly. So we conducted a study on 50 patients, compared and evaluated the functional outcome. We divided them into 25 each, Group A and Group B. Group A consists of patients which were treated with conservative management, and Group B were treated with plating. So the inclusion criteria were patients above 50 years with complex fracture including 3 parts or 4-part fracture. Both sexes were included. Medically fit, willing to participate and to undergo surgery and regular follow-up. Exclusion criteria were skeletally immature patients with pathological fractures, patients with distal neurovascular deficit, shaft of humerus fracture with proximal extension, and fractures dislocation of shoulder joint. All the facilities, equipments required for the present studies were available in our institute. We took proper consent, history, clinical examination, detailed neurovascular examination, associated injuries. We took radiograph of the affected shoulder. After giving primary treatment, immobilization, all routine investigation, pre-operative anesthesia fitness were done. Patients were to be managed operatively, were posted for planned operative procedures. For conservative management, immediate immobilization was done using a shoulder arm pouch or strapping. Vitamin D, calcium and oral analgesics were given. All patients were started on active finger, wrist, elbow movement from day 1, followed by gentle passive assisted range of motion and pendulum exercises were started at 3 weeks once the pain was reduced and as the patient cooperated. Active ROM was started at 7 weeks. After clinical and radiological assessment, full weight lifting was allowed at 6 months and plain radiograph of shoulder AP view were taken at day 0, day 6 week and 6 months. This is the range of motion we examined at with conservative management at 6 months. For operative management, following pre-operative X-rays and baseline investigation, patients were posted for open reduction and internal fixation with locking compression plate after taking informed consent. Position was given under general anesthesia. Deltoid splitting approach was used. Fracture reduced with the help of K-wire. Reduction was achieved in coronal, sagittal and horizontal plane. Remaining fragments were reduced with the help of traction sutures. Once the acceptable reduction was achieved, locking compression plate was applied and fixed with cortical screws. Later, the locking screws were placed in the humeral head. After obtaining the stable plate fixation, K-wires and traction sutures were removed. These are the X-rays of patients treated with the operative management at day of trauma, 6 weeks and 6 months post-operative. And these are the range of motion at 6 months. Observation, both the groups had similar number of cases with associated injuries. Both the group has similar sex ratio. Both the group has similar duration from treatment, from trauma to treatment. Clinical union and radiological union were similar in both the groups. This is the comparison of range of motion in Group A and Group B at 6 weeks and 6 months. Now here we see that at 6 weeks in Group A, that is the conservative group, there was large number of patients with poor prognosis. While at 6 months, there were large number of people in both the group with excellent and good prognosis. Only a small amount of people at 6 months came with poor range of motion. So the locking plate is an implant of choice for comminuted proximal humerus fracture. Plate with attached screw may provide improved fracture stability and healing. Locking the screw to plate mechanically recreates the point of cortical bone contact, which may be useful in the poor cancellous bone of proximal humerus. Patient can be allowed early mobilization, so less chances of joint stiffness. Due to proper reduction and alignment, there is no chance of non-union and malunion. But there is also some drawback of locking plate, like being costly and less easily available. Need for hospitalization in operative management was from 5 to 8 days, while in conservative management it was day 1 or 2 or none. In present study, the outcome of locking plate fixation were similar to those of non-operative treatment. On 6-week follow-up, conservative group has large number of cases with poor ROM, while on 6-month follow-up, both the group had very small number of cases with poor ROM, while large number of cases with good and excellent ROM. Early physiotherapy and good rehabilitation program is the vital key to in both the cases, in both the conservative and operative management for good functional outcome. Thank you.